going to have 30 minutes and Hernia. And tomorrow, is also another 2 hours. Stay with it. And tomorrow, I think 1 or 2 hours. I'm not sure. I'm just getting forward to the so hopefully it will take 2 hours. So we will start. We need to finish early. Usually, where's your class? It depends. Some of them in the female, some of them in the male theater. It depends on the availability. You don't have a friend that, yeah, for shoes? The females are. But really? Assalamu alaikum. Good afternoon or good morning. So my name is Dr. Aziz Barakat. Today I'm going to talk with you about GERD and also Hiatal hernias. So this is your first clinical lecture in this block? No. What did you take so far? Good. We will address also dysphagia in this presentation, but not in details. So good that you took it before. All right. So in this presentation, we will also talk about the normal physiology related to the gastroesophageal reflex, because of not all reflexes are abnormal. We have physiological reflex and we have the GERD, which is the disease, okay? And of course, in every clinical aspect of the topic, we need to address the pathophysiology and then the clinical presentation, the investigations and management, okay? Part of the management, as you guys know, medical management and surgical, okay? So we will touch base upon all these aspects in this presentation. I know the presentation is lengthy, however, we have so many repeated information in the slides, so you guys will notice that. Okay, so first of all, we will start with the normal, the physiology. So the reflex, what do we mean by reflex? So we have the alimentary tract, starting from the mouth, and then the pharynx, and then the esophagus, and then stomach, and so on, okay? So the direction of food, whatever we eat, starts from the mouth and then goes down the track, okay? So when it's going the opposite side, then we call it a reflex, okay? So there is a physiological reflex which is known as burping, and also the vomiting as well could be also part of the normal physiology. And why is that? Because if you think about like overeating or over distending the stomach, then like as a mechanism of defense for the stomach, it will repel the food from the stomach into the esophagus and the mouth, okay? So this is the normal physiology. However, then things will get abnormal, okay? First of all, you have to understand the defense mechanism or the barriers that the body has. So since we are talking about the normal, we have, as you guys know, the esophagus passes through the thoracic cavity and also passes through the abdominal cavity, right? And there is also a pressure inside the thoracic cavity and also a pressure in the abdominal cavity, and they are different because these structures, the esophagus will pass through these cavities, and in between we have the diaphragm, okay? And the diaphragm will control the pressure difference, okay? So we have a higher pressure in the abdominal cavity than the thoracic cavity. So by default, if we are talking about pressure difference, normally the food should go from the stomach into the esophagus, right? So what would prevent the food passing from the stomach into the esophagus normally? The sphincters, exactly. So this is like the main barrier which the stomach has, okay? When this barrier would have a defect, then the disease will develop, okay? So therefore, we're talking about the gastroesophageal reflux disease. So it's a chronic situation, and with the reflux, we're not talking only about food, we're also talking about the stomach acid. We're talking also about the bile reflux, the bile acid, which is coming from the where? Again? The gallbladder, but where actually into the duodenum. Exactly. So we have three main things: the food, the gastric acid, and then the bile acid. So if these are going into the esophagus, then they would irritate the mucosa of the esophagus. And normally, what type of mucosa do we have in the stomach, in the esophagus? Stratified squamous epithelium. And what makes this epithelium intact? What's the main mechanism of this epithelium? The mucus. And where is the mucus secreting from? Again? Goblet cells. So where exactly they are located? Submucosa. So mainly we have mucus cells in the esophagus, which are located in the submucosa. Okay. So by the time, initially at the initial phase of the disease, the mucus will prevent an injury to the mucosa in the esophagus. But later on, even this mucosal layer and then the epithelium would be injured. So here comes later on the complications of the disease, like Barrett esophagus, esophagitis, and we have peptic strictures and so on. Okay, so it's a chronic acid or bile reflux causing unacceptable symptoms or demonstrable pathology, as we said. The passage of gastric content, the acid, the bile, and the food into the esophagus, resulting in symptoms and mucosal damage. Clear? Okay, so in this picture, we are demonstrating the defensive barriers of the stomach. So we have this lower esophageal sphincter, and like it's beneath the diaphragm, so it's located in the abdominal cavity. And also before that, we need to talk about the normal anatomy of the esophagus. So we have the thoracic part of the esophagus, and we have also the abdominal part. The abdominal part is usually shorter, like a few centimeters, and it's located beneath the diaphragm. And since it's located beneath the diaphragm and it's in the abdominal cavity, it will be tethered to the abdominal cavity by ligaments with the diaphragm, and like it's maintained by high pressure. So it would add to the power of the lower esophageal sphincter. Okay. In addition to that, we have here the Z line. So what do you mean by the Z line? So this is the histological junction between the stratified squamous epithelium and the simple columnar of the stomach. Okay, and also since we are talking about the Z line, here at this junction, the longitudinal muscle layers of the esophagus will meet the oblique layers, the muscle layers of the fundus and cardia. Okay, so at this junction, you can see that there is a kink in the structure. Okay, so it's not going straight forward. So this kink also will add to the power of the lower esophageal sphincter. Okay. In addition to that, we have the rugae in the stomach, which will add to the reservoir of the stomach. So it will help in accommodating like the distension, the over distension of the stomach. So all of these are protective barriers. So later on, when we are talking in more details about the pathology of the GERD, we will touch base on every single protective barrier, and we will go into the pathology of these. Okay. So this is another picture of the lower esophageal sphincter. So this is the normal anatomy. So normally we have the esophagus, which is 25 centimeters in length, and it connects the pharynx to the stomach, and it has three segments: one in the cervical, and one in thoracic, and one in the abdominal cavity. The cervical esophagus is 5 centimeters in length. The thoracic is 18, and the most important one, which is the abdominal esophagus, which is usually a few centimeters in length. And this is very important to like the strength of the lower esophageal sphincter, and in order to prevent GERD. So when we have a short esophagus, meaning that we have either very few centimeters in the abdominal cavity, there is a higher risk of developing GERD. Okay. And also later on, when we'll talk about the surgical intervention, the abdominal esophagus will be of high importance. So keep that in mind. So this is the normal anatomy. We don't need to go further. So this is also further details about the normal anatomy. So as we said about the junction of the this is just to showcase that the esophagus has outer longitudinal muscles and inner circular muscles. Okay. And the importance of that is that when the esophagus meets the stomach, it will create the angle of Hess. Okay, and please turn the light on.
I think there might be an issue.
طيب. So we said angle of his. So does anyone know what do you mean by angle of his? Exactly. So this is like, in order to make it short, the angle of his is the junction where the muscle layer of the stomach meets the stomach. Okay. So as we said previously about like the kinky junction, which is the angle of his. Also, this angle is important, like to prevent GERD from happening. Okay. So in the esophagus also we have an upper esophageal sphincter and then the lower esophageal sphincter. And when we are talking about these sphincters, we also need to mention peristalsis. Okay, so the primary peristalsis usually is initiated with swallowing, and as you guys know, like the upper third of the esophagus is like has striated muscles. The middle third has a mix of striated muscles, which are the voluntary muscles, and the involuntary, which are the smooth muscles. And the lower third is completely consisting of smooth muscles. Okay. So when we are talking about peristalsis, so the primary peristalsis is initiated by swallowing, which is by striated muscles. So it will be voluntary. Then later on, when we are talking about the secondary peristalsis, it's going to be the involuntary, because it's going to be initiated in the esophagus due to the distension of the esophagus. So the presence of food in the esophagus. Tertiary esophageal peristalsis is usually abnormal, and we will talk about the dysmotility of the esophagus later on. Okay. In addition to that, so why are we talking about the normal anatomy? Just to like shed light on the barriers that we have in order to prevent GERD. So in this slide, they are talking about the vagus nerve and how it controls peristalsis. There are two important points over here. So they are mentioning here that dry swallows fail to generate peristaltic sequences, okay? And also warm boluses produce stronger contractions. And why is that? And in the esophagus, we have also receptors, okay? We have receptors for acid, and also we have receptors for temperature, okay? So usually warm food will stimulate these receptors for temperature, and it will produce stronger contractions. Okay. In addition to that, like in wet swallows as well, so we need to stimulate the glands in order to secrete like a mucus and activate the secretions in the esophagus, and the secretions will also stimulate stronger contractions. Okay. For example, of course, you had like ice cream or cold food, and sometimes you feel that like these food, especially the cold one, is stuck in your chest, right? And why is that? Because the cold substances will not produce stronger contractions, and therefore it will be stuck in the distal esophagus. Okay. And this is also additional slide about the physiology. So we talked about the pressure difference between the thoracic and the abdominal cavity. So what prevents food from the reflux is the lower esophageal sphincter. Okay, and this is the lower esophageal sphincter. So it's a functional non-anatomical sphincter, meaning that it's a concentration of muscles, of smooth muscles, and normally it's in a tonic state unless there is food in the esophagus, and then peristaltic movement will start, and then the lower esophageal sphincter will relax. Okay. And why is that? Because everything in the gut is controlled by the vagus nerve, which is by parasympathetic. So these muscles will relax with the peristaltic movement. Okay. So it's of a big importance because it's the main barrier against GERD. Okay. And as we said previously, it's located distal to the gastroesophageal junction. The next barrier is the cardium, as we said about the angle of His, and also the rugae of the stomach. Next is the diaphragm, and in the diaphragm we have the crura of the diaphragm, in which it would create the hiatus, which is the opening for the stomach, for the esophagus. Okay, so usually the lower esophageal sphincter and the esophagus is tethered to the diaphragm through ligaments. Okay, and these are the short gastric ligaments. Okay, so when these ligaments are relaxed or abnormally not strong, then it will create hiatal problems. So hiatal relaxation, and then abdominal viscera could herniate into the thoracic cavity. Okay. So if we have an issue with the diaphragm, then it would create problems with the hernia, and then hernias will cause GERD. Okay. And also additional barrier, which is the abdominal esophagus. As we said, if we have a short esophagus, then we will have less power to the lower esophageal sphincter, and then therefore GERD will develop. In addition to that, we have the ability of the esophageal body to clear acid and food, and this is attributed to the receptors that we talked about, and also attributed to the motility of the esophagus. So if we have problems with motility of the esophagus, and can you guys give me examples about dysmotility? Achalasia, excellent. What else? Spasms? Scleroderma, excellent. So in scleroderma, why do we have dysmotility? Exactly. So if we have fibrosis, if we have muscular problem like achalasia or neuromuscular, even in cases like stroke or Parkinsonism, in which we have also problems controlling the swallowing, or controlling the motility of the stomach or the esophagus, then we will lose this barrier. Okay. Biochemical mechanism, which is like the ability to produce bicarbon and mucus, and this is in the submucosal layer. And one of the important factors as well is the gravity. So we always see patients saying that they have this burning sensation in the chest, and this is like exacerbated with their position. So it's worse when they lie flat. Okay, and why is that? Because of the gravity. Okay, so whenever we have patients who have GERD, we advise them to not to lie flat in the bed. So they have to use, they need to elevate their sleep, okay? And also the gastric reservoir function, which is the rugae, and the mucosal rosette as well. Okay, so now we're talking about the pathophysiology. So, like everything related to these barriers, whenever they have defect, then it has a role in GERD. Okay, so the first barrier, which is the lower esophageal sphincter, and then the diaphragm. If there is an issue with the diaphragm, then hiatal hernias will develop. The segment of the esophagus and the abdominal cavity. So if it's defected, then it's called short esophagus. Esophageal dysmotility as well, we talked about them, and reduced esophageal sensitivity to acid, and this is like as a complication of GERD. Okay, impaired gastric reservoir function in many cases. For example, if patients did gastric sleeve, okay, so they would lose a big storage of the stomach. Okay, so food will be stuck in the esophagus for a longer time. Another example, we have patients who are obese. We have patients who are diabetic. So they will develop a condition called gastroparesis, okay, which is delayed gastric emptying. So whenever food is accumulating in the stomach, so there would be a higher chance of this food getting out into the esophagus, okay? All right, so the first defective barrier, which is the lower esophageal sphincter. So if it would lose the ability to contract whenever like peristalsis is not there, then this is the primary mechanism of GERD. Okay, so it will be relaxed while it should be there to contract. Okay, and there are like so many risk factors for that. We will talk about them later on. The next would be hiatal hernia. So all of these are repetitive, as you can notice, okay? But however, the new information over here is that GERD is more common with any type. It's there in any type of hernia, hiatal hernia. However, we will see later on when we are talking about the types. Like the most common type, we call it is sliding hernia. Okay, sliding hiatal hernia, which is type 1. So GERD will be associated with type 1 more than the others. And these are the types of the hiatal hernia. So the first one, we have the sliding type hiatal hernia. And the second one, they call it the paraesophageal hiatal hernia. Type 3 would be a mix of both. So we have a sliding, and then we have also the paraesophageal at the same time. Type 4, we have all of the abdominal cavity viscera, like the whole stomach, the intestines, they will all migrate into the thoracic cavity, okay? So the first one is the sliding. Why do we call it a sliding? Because we mean by the gastroesophageal junction, okay, or the gastroesophageal sphincter. So this sphincter will have a dislocation, okay. So it will relocate into the abdominal cavity while it was there in the it will migrate into the thoracic while it was there in the abdominal cavity, okay. Along with that, we have the cardia of the stomach. It will migrate as well into the posterior mediastinum. Okay. The next one would be the type 2, which is the paraesophageal. So it will go in parallel to the esophagus. That's why they call it paraesophageal. However, keep in mind that in type 1, we have a defect in the lower esophageal sphincter. In type 2, the lower esophageal sphincter will be still intact. Okay? So there wouldn't be any issue with the lower esophageal sphincter in type 2. Therefore, in type 2, we don't have GERD. But however, we have other complications, especially with the hernias. You can think of obstruction. You can also think of twisting of the viscera. So what do you mean by the twisting? What's the medical term for that? Volvulus. Volvulus, and then strangulation if the blood vessels are involved. Okay? So as a result of the obstruction or the volvulus or the strangulation, we will have pain, and we have also belching and other symptoms. Okay? But GERD is not associated with that. Okay. So in type 2, what's migrating into the mediastinum is the part of the stomach which is located in the in this aspect. Okay. So the fundus will be migrating. Okay. However, as we said, the main difference between type 1 and type 2 is the lower esophageal sphincter. So in type 1, the lower esophageal sphincter will be migrating with the cardia, and there would be also, in addition to that, there would be relaxation of the sphincter. Okay, because it lost the high pressure in the abdominal cavity. Remember that. In type 2, the lower esophageal sphincter will be intact. Okay. Type 4, as we said, in addition to the fundus of the stomach, there would be also other organs migrating from the abdominal cavity into the thoracic cavity. And in the X-ray, you will find the intestines or the colon in the chest. So this is another picture demonstrating the difference between the sliding hernia and the paraesophageal hernia. So as you can see, if we are talking about the lower esophageal sphincter, it's going to be intact. However, we have like a part of the stomach at the fundus will go into the mediastinum. Okay. Here in the sliding hernia, the whole lower esophageal sphincter will be in the mediastinum. And in addition to that, we have the cardia of the stomach migrating there. So that's why, like most of the GERD is associated with type 1. Okay. This is also a picture which demonstrates the differences between the types of hernia. So in type 1, as we said, here you can we zoom? How can we zoom?
Get out. Get out of the
Okay. Type. So this is type 1. As you can see, there are like few differences between type 1 and type 2, and this is very important. So we have attenuated phrenoesophageal ligaments. So these ligaments are the ligaments which make the lower esophageal sphincter tethered to the diaphragm. Okay. So when we have these ligaments lax, and they are not strong, then we will have the hiatal hernia. Okay, so attenuated in type 1, and in type 2 it would be normal. Okay, so this is one difference. The other difference is that the lower esophageal sphincter is there in the mediastinum. However, in type 2 it would be it's in place. Okay, the third one is that as we talked about the kinky junction between the esophagus and the stomach, which is the angle of His. In the type 1 hiatal hernia, we will have this angle reduced. So you will have straightening of the esophagus into the stomach. Okay. However, in this aspect, we still have the angle of His and the paraesophageal hiatal hernia. Okay. So these are the three main differences. And please focus on these because it might come in the exam. Okay. So how to go back to the presentation? Yeah. Good. So okay. So when we talk about the pathophysiology, especially about the hiatal hernias, the main aspect, why do we have hiatal hernias, is that because of the laxed ligaments, the phrenoesophageal ligaments. Okay. The sliding hernia is the most common type of the hiatal hernias, and usually it's asymptomatic in most of the cases. However, like if it would produce symptoms, it will produce symptoms like related to GERD. So it will be related to the reflux of food or acid or bile acid into the esophagus. Okay, so in case there is like the stomach acid passing into the esophagus, what would be the most common or the typical symptom? Heartburn. Okay. In addition to the heartburn, what do we have? If we have like undigested food passing from the stomach into the esophagus and then later on into the pharynx, regurgitation. Okay. What else? Excellent. So we have also symptoms related to the respiratory tract. Okay. So if we have aspiration of the acid or the food particles into the respiratory system, so patients would present with the symptoms related to like continuous persistent coughing. It could be related to like similar symptoms related to asthma. Okay, so patients would be short of breath. They usually complain of recurrent upper respiratory tract infections like tonsillitis, and also tooth decays because of the like acid, the presence of acid in the oral cavity. Okay, but the most common one is heartburn. Okay. And also keep in mind is that the larger size of the hernia, we have the high risk of GERD. Okay. Okay. So the second one, which is the paraesophageal hiatal hernia. So here is the main difference. So the gastroesophageal junction would remain anchored to the abdomen, and therefore it will be in place. Okay, so that's the main difference between the paraesophageal hiatal hernia and then the sliding hernia. In the paraesophageal hiatal hernia, we have the fundus which is migrating in the mediastinum, which is located in the greater curvature. Usually the lesser curvature will remain in place. Why is that? Because the lesser curvature is connected to the intestines, okay? So it will be anchored in its place because of the attachments of other organs, okay? However, in this paraesophageal hiatal hernia, we will have the risk of valvulus, okay? In the mixed type, we have both. Like it depends on the size of the hiatal hernia. There might be both. So hiatal hernia in addition to paraesophageal hiatal hernia, okay? And this type is more common than paraesophageal hiatal hernia itself. And why is that? Because we said about the hiatal hernia, which is type 1, is the most common type. The mixed type, which is type 3, would be a complicated type 1, okay? So it would be type 1, but with a larger size. So when we have the fundus also migrating with that, then it would be classified as type 3. Okay, so as we said about the symptoms, usually it's asymptomatic, but it would produce typical reflex symptoms of heartburn, regurgitation, dysphagia, according to like the severity of the hiatal hernia. So usually type 2, 3, and 4, they produce like symptoms other than GERD, like postprandial pain, bloating, early satiety, and mild dysphagia as well, okay? However, remember, type 1 would produce symptoms related to GERD. 2, 3, and 4 would produce symptoms related to pain. So postprandial pain, bloating, early satiety, and dysphagia, okay? And also there would be other complications like valvulus obstruction, strangulation, infarction, and so on, okay? Okay, so the presence of hiatal hernia is not sufficient to make the diagnosis of GERD. So if hiatal hernia is there, it doesn't mean that GERD will be there as well, okay? Because like most of the cases will be asymptomatic, and usually like whenever they will find maybe even incidentally, then if it's not producing symptoms, we usually don't do anything. So it's going to be um, like like unless it's producing symptoms, then we have to intervene and manage, okay? But if it's asymptomatic, then we don't have to do anything, okay? Many patients with hiatal hernia do not have symptoms or mucosal damage secondary to reflux, and they do not require treatment, as we said. The next defective barrier, which is related to the length of the esophagus. So, as we said about the short esophagus. Next one is the dysmotility. So dysmotility is important, especially like when we are going to treat GERD, okay? Because later on, when we are going to talk about the surgical management of GERD, we will talk about the fundoplication, which is the wrapping of the stomach around the lower esophageal sphincter, okay? However, in this like wrapping management or fundoplication, we have like many types, okay? The complete wrapping, which is called Nissen fundoplication, the 360 wrapping around the lower esophageal sphincter, is not like preferred in cases in which patients have esophageal dysmotility. And why is that? Because when we are going to do the wrapping, then if patients have dysmotility, they will have dysphagia, okay? And you are not going to treat the problem. So you are going to do complications, okay? So therefore, it's very important before the management to exclude esophageal dysmotility, especially in patients who have symptoms, because maybe the symptoms are related to the dysmotility rather than hiatal hernias, right? So as we will see later on, whenever we talk about the investigations, how to investigate GERD, usually we are talking about endoscopy, upper GI endoscopy. We are going to talk about barium swallow studies in order to assess the motility, and also we are going to talk about the pH manometry, okay? So therefore, before intervention, before even surgical intervention, we have to do all of these in order to exclude esophageal dysmotility, in order to exclude as well other complications like Barrett esophagus or even adenocarcinoma, okay? All right, so abnormal esophageal peristaltic activity is found in 70% of patients with GERD, okay? And these dysmotility are classified as like ineffective peristalsis or hypomotility. So hypomotility like gastroparesis, okay? There is also a controversial part about the dysmotility, like is it the cause of the GERD or GERD is causing dysmotility, okay? So sometimes dysmotility comes before GERD, or as a consequence of GERD, there would be also dysmotility, okay? Dysmotility can be treated. يعني there are medications which can treat dysmotility, and also there are also like surgical procedures which can treat dysmotility as well. So therefore, it's very important, like in order to understand the patient, we have to take history, full history of the symptoms, okay? How and when did they develop? In addition to that, we need to investigate the cause, because if we know the cause, we know then how to treat, okay? All right, so again, so if you notice, we talked about all of these in the beginning, but now they're talking about it again and again, but in more details. Sure. Okay, so we will take 5 minutes break and then we will come back, okay? Guys, we need to start again. طيب, now we're going to be done with the like pathology related to the normal anatomical and physiological barriers. Here are the factors that are associated with GERD. Okay, so anything that would increase the pressure in the abdominal cavity, factors like pregnancy, morbid obesity as well, it would contribute to the relaxation of the lower esophageal sphincter. Okay. In addition to that, we have the chocolate, coffee, alcohol, and fat. So all of that, the intake of these substances will have a direct effect on the lower esophageal sphincter through relaxation. In addition to that, it will increase the acid production. Okay. We also have like the overdistension of the stomach. So large meals, cigarette smoking will have similar effect like the caffeine and chocolate. Drugs that will affect the contraction of the lower esophageal sphincter, like the anticholinergic, the calcium channel blockers, will also contribute to the relaxation of the lower esophageal sphincter. Systemic sclerosis, as you guys said, it will lead to fibrosis and the ineffective contraction. And as we said about the hiatus hernia, and also after treatment of achalasia, because it will lead to relaxation of the lower part of the esophagus. So now we're talking about the clinical presentation. So as we said, in most of the cases, it's going to be asymptomatic. However, if we need to talk about the presentation, we have to talk about the typical symptoms. So typically, it will produce heartburn, which is a burning sensation in the chest, and this is the most common symptom. Okay. Usually, it will appear after meals, in few minutes to hour. It's gonna be worse with the position, like worse with the lying flat or bending over. And as we said about gravity, it's going to be very important. Patients with GERD, we usually advise them to like not to lie flat on bed. Okay. Also, it occurs. This heartburn occurs secondary to acid reflux. Okay, so remember that not all reflexes are attributed to gastric acid. So we have also food, and also we have bile acids. So the mainstay of treatment is not to not to treat all patients with PPI, which is the proton pump inhibitors, because as we said about the barriers, one of them is the like the acid reflux. But if we have hiatal hernia and all of that, PPI will not going to treat the cause. Okay. So the next presentation would be regurgitation, which is the burping of indigested food, and this would suggest more severe and progressive disease. Okay. The next one is dysphagia, and dysphagia would represent a mechanical obstruction. So usually in GERD we don't have dysphagia. However, if we are talking about the complications of GERD, like peptic strictures, esophagitis, and then the development of Barrett esophagus. So I guess you took a lecture about Barrett esophagus, right? So in Barrett esophagus, what's going to be the mucus lining of the esophagus? So they're going to be an intestinal type of epithelium, which is like a columnar type of epithelium with goblet cells. Okay. So in that case, then dysphagia will develop. Okay, and it's going to be with solid food, and then it will be progressive. So it will increase in severity based on the progressive of the progressiveness of the disease. And we will talk about the management of dysphagia later on. One of the differential factors, differential diagnosis for dysphagia is that, as we talked about, dysmotility. Okay, so it could be attributed to dysmotility. It could be attributed also to strictures and Barrett esophagus. So therefore, if we have dysphagia, we have to do endoscopy in order to see what's going on. Okay. And also, in addition to that, we also talked about other investigations like the manometry and the barium study. It's very important. Next presentation, which is like very rare, it's the abdominal pain, and mainly in the epigastrium, and it could be misdiagnosed also with cardiac pain, especially. This is what they call it atypical myocardial infarction. So usually elderly females, they would present with the epigastric pain. Okay, this is for atypical MI. And also we have bloating and nausea. In addition to that, we also talked about the upper respiratory symptoms. So patients who have acid reflux, they would have recurrent tonsillitis or pharyngitis. In addition to that, they would have persistent dry cough. Sometimes it's misdiagnosed with asthma, okay? And the patient will be like on inhalations for like a couple of like a long time, and they wouldn't see any improvement, okay? Therefore, after that, they're going to be investigated for GERD, and most of these cases, they would be related to GERD, actually. So in addition to that, they would have hoarseness of voice, cough, wheezing, which is like similar presentation of asthma, okay? In addition, as we said about the tooth decay, so the presence of acid in the oral cavity would attribute to the development of decays. And this respiratory symptoms would be there in 10% of patients, okay? And patients would, in which they present with such cases, they need to go with the 24-hour pH monitoring in order to see like the presence of the acid in the pharynx, okay? This is how we diagnose these cases. Also, like in rare cases, there would be the development of pulmonary fibrosis because of GERD. So, talking about the investigations, so the upper GI endoscopy would be there in order to see like the visualize the mucosa directly, okay? In the upper GI endoscopy, we're going also to locate where exactly the gastroesophageal junction, okay? In addition to that, it will give us the advantage of visualizing the mucosa, and in order to diagnose if there are strictures, if there is esophagitis, or even Barrett esophagus. And also the endoscopy, it will enable us to take biopsies in such cases, okay? The next one would be the 24-hour pH monitoring. And this is like the standard investigation in such cases. So usually, like it's of two types: the wireless pH monitoring, and then the wired. Okay. Usually they go with the tube through the nasal cavity, and they attach the probes in the pharynx and the esophagus as well. The probe in the esophagus usually a few centimeters above the gastroesophageal junction in order to see the presence of acid. And they ask as well the patients to record their symptoms in a note in order to correlate it with the analysis of the probe, okay, and the presence of acid. The wireless type is like if we are going to do endoscopy, then we're going to attach the probes of the pH monitoring through the endoscopy. Okay, so there is no need to insert any nasal tubing. Okay, and usually these probes they will like detach from its place, and they will go out of the body through the alimentary system in 7 days. Okay. Okay. So the esophageal manometry is the third one. So the manometry will be very important in cases we suspect that there could be esophageal dysmotility. Okay. In addition to that, it will enable us to know the length of the esophagus, and to also to record the activity of the lower esophageal sphincter. Okay, so it would give us the mean resting pressure. It would give us when there would be relaxation of the lower esophageal sphincter, and so on. So, like, it's of importance that you take into consideration these 2 points. So the longer the length of the high pressure zone of the lower esophageal sphincter, which is like inside the abdominal cavity, the greater the barrier of the reflex. So it's related to the length of the esophagus. Okay, and the longer the length of the intra-abdominal components, the greater is the barrier of reflex. So it's the same thing. Okay, so these are like analysis of the results of the manometry, esophageal manometry. So the normally patients should have more than 80% of the motility of the esophagus related to peristalsis. Okay, if it was less than that, as we said, for esophageal dysmotility, it's very important for us to diagnose it before any intervention. Okay, so if the peristalsis was less than 60%, or with the distal esophageal amplitude of less than 30, which is like related to pressure gradient, then these patients are not suitable to undergo complete fundoplication. Okay, because if they undergo niacin fundoplication, they would develop dysphagia because of abnormal peristalsis or incompetent peristalsis. And also, one of the investigations is barium swallow studies, which is the contrast study. So the complications of GERD. So usually this part is related to like the pathology. So we will touch base briefly upon it. So as part of the presence of acid or bile acid in the esophagus, there would be mucosal irritation. So esophagitis will develop. If the esophagitis is severe, this means that we are losing the mucosa, then ulcers will develop. And if ulcers are there, there might be also upper GI bleeding. Okay, upper GI bleeding and peptic strictures. So if there are recurrent ulcers, we're going to develop strictures. Later on, if there is fibrosis and metaplasia, then there would be Barrett esophagus, and also GERD would make the muscles of the esophagus contract. So the esophagus will lose its length. Okay, and therefore they're going to be also short esophagus. In addition to that, if there are respiratory symptoms, then it would cause respiratory complications. So this part of slides are related to the lectures of the pathology. So we will leave it to Dr. Imad and Dr. Oban. So Barrett esophagus. We said about the metaplasia and the turnover of the intestinal type of epithelium. What is of importance is how to investigate and how to treat. Okay, So with Barrett esophagus, usually the investigation is with upper GI endoscopy and sometimes with the barium swallow studies, okay? And how to treat. So before how to treat, the complications for Barrett esophagus. So we have Barrett ulcers. Um, as we said about the complications of GERD, we have also ulcers which are related to GERD. But in GERD, the ulcers which are related to GERD, we will have it in the lower third of the esophagus because of the presence of the acid. But for Barrett esophagus, if there would be ulcers, it's going to be in the middle third of the esophagus. In addition to that, we have stricture and also progressive dysplasia and adenocarcinoma eventually. So the treatment, again, it's related to the progressiveness of the disease and the symptoms. So if there was only Barrett esophagus but without symptoms, usually patients need to go surveillance with endoscopy and biopsies. So it's going to be annual, okay? However, if it's complicated and producing symptoms, we have to keep patients on PPI. And in addition to that, we might consider surgery for anti-reflux disease, because we need to prevent the progressiveness of Barrett esophagus into adenocarcinoma. Okay, and if adenocarcinoma is there, or even if we have dysplasia, if we have high-grade dysplasia and adenocarcinoma, then the treatment would be with the resection of the esophagus. Okay. So these are the treatment. So with Barrett ulcers, the patients usually they require to have long-term PPI treatment, usually for months, like minimum of 6 weeks and up to 3 months of treatment. Okay. If there is strictures, we can treat it with endoscopy through ballooning. If endoscopy failed, then we have to do surgery for that. Okay. As we said about dysplasia, so if there would be high-grade dysplasia and adenocarcinoma, so the treatment would be with the esophagectomy, which is the resection of the esophagus. So this is also repeated from previous slides. Yeah, so as part of the complications of GERD, we said that GERD might lead to shortening of longitudinal muscles of the esophagus, and the short esophagus is also associated with the hiatus hernia. So in hiatus hernia, we're going to lose the part of the esophagus which is there in the abdominal cavity. So that's why they call it short esophagus. Okay. So what's the treatment of GERD? You have to keep in mind one thing, that the long-term use of PPI is not the solution. Okay. Sometimes patients used to take PPIs, but we are going to only solve one thing, which is the acid reflux. Okay. But keep in mind, not only acid is going to go back into the esophagus, but food and bile acid. Okay. So if patients have symptoms of regurgitation, so that's like a surgical indication for GERD management. Okay. So usually, if GERD was diagnosed with like 24 pH monitoring and endoscopy and so on, so if it was asymptomatic, then we don't do anything. But if it's producing symptoms, then we have to do like medical intervention. Okay. But for lifestyle modification, we usually ask patients to elevate like the bed with pillows in order not to lie flat, and avoid like having large meals, avoiding eating also late at night, like especially before bedtime. And why is that? Because it's going to exacerbate the regurgitation. And also like related to the type of food. So as we said about the chocolate, about the fat, about also the caffeine, about the smoking as well. So all of these they need to avoid. Okay. Medical management, as we said about PPI. So like if there is heartburn, usually they would start management with 6 weeks of PPI, and then they would evaluate like if symptoms disappear after that or not. Okay. Um, after this 6 weeks of PPI initial therapy, then if symptoms persist, they would do further investigations. But usually, whenever a patient presents with heartburn, it doesn't mean that they should undergo endoscopy and 24 pH monitoring and so on. So usually they would start with PPI management for 6 weeks. After that, if it failed, then we have to do the investigations. Okay? So, as we said about the PPI, so it's not the only management that we need to consider. So, with the PPI management, 70% of cases will resolve, and there would be also like 50% of cases who in which they have severe esophagitis will resolve as well because of the PPI. But keep in mind the other 50% of this severe esophagitis. Okay. And also the PPI will not prevent the regurgitation and the bile acid reflux. So we have to think of like other methods of management. So here we are talking about the surgical management. So what would be the indications for surgery? If we don't have complete resolution of symptoms after PPI management, if we have relapsing of symptoms, and like if patients were on long-term treatment with PPI and without improvement, if patients were like not compliant with medical management, and in such cases, even surgery would be difficult for them, because after surgery, they have to be compliant with the type of food and food hygiene. Okay. In addition to that, if we have complicated GERD, so if we have esophageal peptic strictures, if we have ulcerations, if there would be also persistent esophagitis, persistent regurgitation. So regurgitation alone is an indicative of surgery. Okay. In addition to have if we have severe pulmonary symptoms, and if there is dysplasia. So there is a preoperative evaluation. So like every patient who's a candidate for surgery has to go through endoscopy, has to go through manometry in order to exclude dysmotility in order to exclude also and treat as well dysphagia like Barrett esophagus, esophagitis, and so on. So what would be the surgical options? So that's going to be the last part of this presentation. We have two types of surgery. We have the fundoplication, and we have also the gastropexy. Okay, so pexy means that fixation. We're anchoring the gastroesophageal junction onto the diaphragm. Okay, the fundoplication, we're going to cut down the ligaments that attach the cardia of the stomach into the diaphragm, and then we are wrapping the cardia of the stomach into the lower esophageal sphincter in order to increase the pressure and increase the power of the lower esophageal sphincter. And the fundoplication is of many types. Niacin fundoplication is a 360 degree wrap, and this part of the fundoplication, which is not preferred with the esophageal dysmotility. And why is that? Because it will lead to dysphagia later on after surgery. In addition to that, we have fundoplication of lesser degrees, like 270 and 180. So this is a picture of the fundoplication. So again, as we said, we're going to cut the ligaments which attaches the stomach into the diaphragm, and then we're wrapping the cardia of the stomach into the lower esophageal sphincter. And also with these fundoplication, we have two approaches, one intra-abdominal and one thoracic, but you don't have to know all of these. Okay, so just remember the concept, the fundoplication and the gastropexy. In addition to that, we have additional concept, which is the gastroplasty. So as we said about the short esophagus, so if we have patients who have short esophagus, meaning that we don't have enough abdominal esophageal segment, okay, what can we do is that we pull the esophagus into the abdominal cavity and we do the wrapping. This is in case we have enough length. However, in cases of short esophagus, there wouldn't be like this privilege. So what they usually do is that they increase the length of the esophagus with the cutting the stomach. So they change the shape of the stomach. That's why they call it a plasty, gastroplasty. We will see in these images. So this is the Colles gastroplasty. So this is in case of short esophagus. So they cut down the fundus and then they wrap it into the esophagus just to increase the length, and then this part of the stomach, they wrap it around the esophagus. So they will change the shape of the esophagus. In addition to that, they will do the wrapping around the lower esophageal sphincter. Okay. So, and also there would be also the complications of the surgery, which is like pneumothorax and so on. But at this level, you shouldn't know about the complications of surgery. Post-operative management. So we have a diet program. So usually a few days after the surgery, patients are only allowed to drink like liquids. And also like 1 week after, during the first week of surgery, they will they will have pureed type of food, which is like a creamy food, in order to to have like the benefits of the regular food. And after that, they would like about 1 month of surgery, they will have only soft food. And about 1 month after the surgery, they are allowed to go back to the solid food. Okay. In addition to that, so you would appreciate that, like in order to reduce the symptoms of the GERD, people were on PPI for a long time before the surgery. So after surgery, they would go into weaning therapy, meaning that they will decrease the dose and decrease like the length of the therapy after the surgery, but they will not stop it completely after surgery. So that's it for this presentation. Any question?
You said that for hiatus hernia, PPIs don't really manage problem.
Yes.
But shouldn't you give them just in case they do end up developing GERD? Because it's type 1 happening.
If it's symptomatic, then like symptomatic meaning that it would produce heartburn, it will produce also dysphagia, then you would give them PPI, but you have to investigate further. You have to do. If it's not symptomatic, then you will delete. You wouldn't give PPI. Okay? All right. Good luck.